Well, good evening, everybody. Good evening, and thank you for joining us for the virtual town hall for the 37th annual National Week of Prayer for the Healing of AIDS. And I'm so grateful that each and every one of you are joining us on this evening. While you're joining us, take a moment, let us know in the comments where you're joining us from, and also just give us a shout out here at the Balm In Gilead. At this time, without any further ado, I want to introduce the founder and CEO of the Balm In Gilead, Dr. Pernessa Seal.
Well, hello. Hello, Carrie, and thank you, everyone, for joining us on this very, very special virtual town hall. There's a lot going on this evening, and we are just so excited that you have taken the time to join us for this 37th National Week of Prayer for the Healing of AIDS.
Absolutely. Thank you so much, Dr. P. Thank you for your leadership. Thank you for your steadfastness. 37 years is a long time.
Woo! Long time, long time, long time.
Long time. And so also, if you have any questions as we go through this live stream on tonight, please drop it in the chat and we'll take a moment to look at questions as they come about. So Dr. Seal and I, we're going to jump into a quick conversation. 37 years. 37 years. Started
and
with
all of God's grace.
And all of God's grace. Started with a little idea. Take us back for a moment to that moment that the little idea dropped in your spirit. Like, how did you feel? Like, what was that moment like?
Oh, my. Well, in 1989, I was between being a research scientist to being an AIDS educator in the height of the AIDS epidemic in New York City. Had just gotten a job at Harlem Hospital, was excited to be living in Harlem. And I really was devastated by everybody. It seemed like every bed was filled with people who was living with HIV. Really, they were actually dying of HIV. This was before AZT and all of the great treatments that we have today. But I was, Carrie, I had to go to the bedside and nobody was coming, and so my question was, wait a minute, where's the church? Where are the mothers of the church? Where are the pastors? A matter of fact, where are the mothers and the fathers and the sisters and the brothers? It was a mess. It was just a messy time in New York with AIDS epidemic. And I remember one morning, this is the second day of my new job, and I'm living in a little small apartment. I mean, a studio apartment, but as big as a plate, if you will. And I hated this job. I hated it because I was not equipped and didn't take a job where I had to go and, and talk to people with HIV, but they wanted more than talking. They wanted more than what I was asked to do. They wanted someone to sit and pray and minister to them. And, I was like, Lord, I was talking to the ancestors that morning. Lord, I don't want to do this job. And I said, you know what? We have to pray on this. And when I said we had to pray, it was like a little idea. The room just burst into light. And in that moment, the Harlem Week of Prayer for the Healing of AIDS was born. And, I thank God for the folks, Jolene Connors, who was my boss at the time, Dr. Wafa El Sada, who was my boss at the time, who didn't know me from Adam, and definitely the faith community of New York, who definitely didn't know me. I was not clergy. I was a woman. I had bald hair, more hair on my head now than I did then. But they saw something in me. But more than that, they were looking for a way of addressing this devastating epidemic in Harlem.
Yeah. So you often talk about this little idea. Can you tell us and kind of bring it into today's context, as many that may be watching us are tussling with an idea of what they want to do? What is the power of the little idea?
I love that. The power of an idea. The power of an idea, the precursor of an idea is the fact that you must believe that God is calling you to do something. And that's the key. The key is the power of belief. Because I think many of us get an idea. You know what I mean? Yeah, I got this idea and I know it'll work. But for me, it was the belief it was the belief that I believed that God was calling me to do this thing that I had no clue about. I had no money. I didn't know these people on this job. I didn't know anything about Harlem, but I believed that God was calling me to do this. And I believed also that if God was calling me, he was going to make a way out of no way. And I
Yeah.
think for those of you who are wrestling with an idea, don't do it if you don't believe that God is calling you. If you believe God is calling you, then you must step out on faith and get God's work done. But if you think, well, I just think I just thought this up. If you think it's you thinking, then leave it alone. But if you think God is calling you to do it, then get yourself out of the way and let God use you to a greater good.
Absolutely. You said God is going to make a way out of no way. So I dare somebody to put that in the chat right now. God is going to make a way out of no way. Wow, that's really good. So as we look at the HIV/AIDS crisis back in the 80s, how did you engage and mobilize? So let's take away the first year. Let's take away the first year of the Week of Prayer, the Harlem Week of Prayer. We understand, you knocked on doors, you met with powerful leaders in Harlem. But what was it after that first year? Like, what was that like? How did you engage even more faith leaders, not just in Harlem, but beyond the confines of Harlem?
Well, people began to hear about what was happening in Harlem, and they
Hmm.
began to call me. I can remember my dear sister Belinda Dunn up there in Boston, and folks around the country was like, how in the world are you successful in mobilizing Black preachers of my HIV? Everybody was trying to do it. And again, in my belief that God was calling me, I had hit something successful. So people were beginning to call and say how. And I was like, come to Harlem. Let me show you. Come to Harlem. And then Emory University, Dr. Stephen Thomas called and said, we want to come in and, reach the researchers. We want to come and see how this is doing. And from that conversation and getting in touch with CDC came to us as well, and wanting to see how this mobilization was going and could it have legs outside of Harlem. And so it was CDC and Emory University that we stepped out from Harlem, and it became, the first thing was, was the Black Church Week of Prayer for the Healing of AIDS.
Hmm.
And then we looked at, I think Nashville, Dr. Reverend Sanders was one of our first. Once we stepped out of Harlem, Belinda Dunn and some others around, we had 5 cities. I can't remember those 5 cities right now, but I know Atlanta and Nashville and Boston was one of them. That we stepped out. And then from there, we just began to mobilize and mobilize and mobilize. And then it became a national day. And I was just looking at something about ancestors and black colored troops um, fighting in the Civil War. And I was in the National Archives about 3 days ago. And there was the National Archives about the National Day of Prayer, the first National Day of Prayer before it was a week. We, the Balm in Gilead, we did the African American Clergy Summit at the White House. And you can
Hmm.
imagine, a couple of days ago when I was looking for something and that popped up, in the National Archives, I knew you heard me scream because I did.
Yeah. Yeah.
That the record book shows that the Balm in Gilead mobilized. And I remember that, some of our leaders who are now on the other side, were there that day for that clergy summit at the White House. And it was just, and from there we said, well, we the Black people, we need more than one day to do anything. So
Right.
it became a week. And then from the Black church, we said, you know what, we need everybody. We just don't need Black church, but we need everybody in this fight. So we moved it to the National Week of Prayer for the Healing of AIDS.
Wow, wow. This is such a historical journey. So I hope those of you who are taking notes are, seeing that oftentimes your ideas don't start, or your ideas don't manifest in day one. So we're seeing manifestation happening even now, 37 years later. So over the decades, the landscape of HIV and AIDS treatment and awareness has changed. How do you see the impact of the National Week of Prayer for the Healing of AIDS in our current era, like as compared to the 80s and the 90s?
Hmm. Hmm. Well, I want to, that's a very interesting question. It's a great question. But I want to go back and begin the answer with an experience I had maybe 7 years ago when the Balm in Gilead was rolling out our Southeast Diabetes Faith Initiative.
Hmm.
And there was a woman who was she was from Alabama. I think she was in
Hmm.
Birmingham. And she was becoming one of our lifestyle coaches in Birmingham. And she came to the office we're now in Richmond, and said, "You don't remember me, but I was at the first Harlem Week of Prayer for the Healing of AIDS." And I was like, "Wow." She said, "I was a funeral director." I'm like, "You were a funeral director?" She said, "Yes." She said, "All of the funeral directors in Harlem was there for the first Harlem Week of Prayer for the Healing of AIDS." And I was like, "What?" She said, "Yes, we were mandated to come by the Reverend Dr. Wyatt T. Walker. Wyatt T. Walker got on the phone and called every funeral home in Harlem, because at that time, no funeral home was burying. Nobody didn't want to touch a body, did not want to do it. And Dr. Walker called every funeral home and mandated that they come to the week of prayer for the Harlem Week of Prayer for the Healing of AIDS." And that, even though we talk about what churches didn't do, we had a leadership in Harlem that was being impacted. The churches, Dr. Wyatt said he'd already buried 70 men from his congregation by 89, but he also not just supported the Harlem Week of Prayer, but to take another level of action to call and say, listen, funeral homes, we have got to stop this. And so I think that there are many, many leaders around the country who have had that kind of advocacy spirit, but I think we need
Hmm.
to see more of it today. The billboards are not there anymore. We're not talking about HIV like we used to. It's not on the radios. We're not having all of these forums, even though we have technology that we didn't have in 89. It's kind of the silence is just back. It's still there. The stigma is still there. And I think that we now have a whole new generation was not even born in 1989 that's impacted, that's affected by HIV. And so even though we have the great treatments, and it's just the interventions, the treatment interventions are phenomenal. Prayer changes things, but we still have these high rates of HIV among our brothers and among our sisters, you know, and the stigma is still real. So I think we still have a long way to go. And then we have a new administration where you now cannot see any HIV work in CDC. I just got a text yesterday from Uganda that said all of the programs in Uganda and Kenya and Tanzania that was funded by USAID are now closed. People don't have no jobs. So I'm in a very interesting place now when you look at my work over 37 years in 6 African countries and around the world. And I can remember Bishop Yvette Flunder and I, we were beating up. I mean, we were whipping up CDC. We were there. Reverend Sanders, Benny Prim, we were at CDC all the time, lighting them up. I mean, we were gangsters, making sure that, CDC was being responsive to the Black community and HIV, as well as in DC. I remember writing legislation with Deborah Fraser House at a beautician shop. We were just gangsters, and to now come to a place with another administration where all of this is being taken down. You cannot imagine what I say in my house in private. How about that?
Oh, I can imagine. But Dr. P, we appreciate you. We thank you so much for the years that you have been on this journey. Oftentimes, we don't fully understand as we are walking along the journey, but there are many who are watching. There are many who are grateful. There are many who are still taking notes and reading those notes from years past. So we thank you so much for all that you have done over these 37 years. of the National Week of Prayer for the Healing of AIDS,
Well,
and the Balm In Gilead. Go ahead.
Thank you, Carrie. And I know we have to go, but I want to also thank you. I want to thank you for, you've been with the Balm for 17 years, and my team at the Balm is the greatest team in the whole wide world. And it goes back to that little idea. It doesn't, if you're leading and no one's following, are you really leading anything? And so to be at the 37th year and to come on and have this conversation with you, and to see all the great work to have you do all the great work at the Balm in Gilead, where, I used to wash the dishes, do the bottle work, get the lunch, do everything. And now I don't have to do that. You know what I mean? I have to do a lot, but I don't have to do, and to have, such brilliant minds around me like yours and Pam and Keisha and all of you. It's really the testament of God's grace, because we're now in legacy time, and so having an idea moving forward 37 years, but we don't want it to end here. And because God has built a team around me, I can sleep at night knowing that the work will go forth. And that indeed is the blessing.
That's beautiful. That is beautiful. Y'all give it up for Dr. Pernessa Seal, the founder and CEO of the Balm in Gilead. Thank you so much. And she'll be back towards the end of our presentation on this evening. We thank you again for joining us for our virtual town hall for the 37th National Week of Prayer for the Healing of AIDS. Again, I'm Carrie Goodman, program consultant for the Balm in Gilead, and I want to thank you for this opportunity to lead you on this evening. It's at this time that we're going to move into a powerful panel discussion. Over the last few years, we've presented the doctor and the preacher. And so this year with this virtual town hall, we decided to shift it a little bit, and we have a panel of doctors that will have a powerful and impactful conversation. So at this time, I would like to present our moderator for this evening in the person of Dr. Ulysses Burley. Dr. Burley, we turn it over to you.
Thank you, Elder Carrie Goodman, and thank you to Dr. Pernessa Seal for your visionary leadership. I know we are no longer in Black History Month, but as Black people, we celebrate Black History Month year round, and it is a pleasure to not only be able to talk about Black history in the context of the HIV and AIDS movement, but to be able to talk with Black history in the flesh. And Dr. Seal, you are indeed Black history in the HIV and AIDS movement. And we are so grateful that you are still here with us, fighting, encouraging, mentoring, so that we can continue the legacy and the work that you started more than 37 years ago. Again, my name is Dr. Ulysses Burley, and I am the founder of UB The Cure LLC, which is a Chicago-based organization that operates at the intersection of faith, health, and human rights. I am a clinical immunologist by primary training, but I'm also a minister. And majority of my career has been at the intersection of faith and HIV. I'm somebody who believes in divine alignment. And I don't think it is a coincidence that the Week of Prayer for the Healing of AIDS is the bridge between Black History Month and now Women's History Month, the bridge between National Black HIV and AIDS Awareness Day and National Women and Girls HIV and AIDS Awareness Day. Dr. Seal founded the National Week of Prayer for the Healing of AIDS long before many of these designations were federally recognized, but God aligned it such that the people who were most disproportionately impacted by HIV, Black and brown people, women and girls, women of trans experience, were brought together by healing and prayer. And so it's my pleasure to be able to moderate a conversation this evening with people trained in healing and people who are trained in the acts of the Spirit in prayer, and to be able to operate at the intersection, because we are people who believe we need both. And so it is my honor to welcome into the conversation Dr. Pamela Payne Foster, who is a prevention medicine and public health physician and professor of community medicine and population health at the University of Alabama, and Dr. Alicia Mirage Bass, who is assistant director of the Center for AIDS Research at the University of North Carolina. We will also be joined later in the conversation by Reverend Dr. J.C. Howard, who will provide a lens for faith communities around HIV and health equity. Before we dive into our conversation, I just want to briefly provide a landscape of where we are now in the HIV and AIDS epidemic. Now, more than 44 years into the epidemic, it has claimed more than 40 million lives worldwide. We currently have in excess of 40 million people who are currently living with HIV. And here in the United States, we have 1.2 million people living with HIV. But I emphasize the living part, because as Dr. Pernessa Seal eloquently told us in her introduction, she founded the Week of Prayer for the Healing of AIDS because people were dying. Not only that, people were dying alone. And so I'm happy to say that people are now living with HIV and AIDS. We have come a long way since AZT that Dr. Seal referenced in 1986, 1987, where we didn't have anything to throw at HIV. And so we found something that was on a shelf that was created for something else and said, let's try this. Maybe this will work. It initially showed some promise, and then we realized that it was doing more harm than good, and that HIV was really just smarter than the particular medication. But it took another 10 years for us to develop combination therapy, antiretroviral treatment, and it truly revolutionized the HIV and AIDS epidemic, such that people no longer had to take 25, 26 pills a day to stay alive. People no longer had to live into this death sentence from an HIV diagnosis. People could live full and healthy lives with HIV and continue to thrive as the science and the medical community tried to find further advancements to better life and love, as we are gathered today on this week of prayer for the healing of AIDS. And so since then, we have had more developments. We now have more than 40 different antiretroviral therapies across 8 different classes. We've been able to leverage those combination therapies for effective prevention through pre-exposure prophylaxis, where we know that we can, with 100% certainty, prevent the acquisition of HIV via sex for people who have access to PrEP. Not only that, we have pill formulations, but now we have injectable options for treatment. And this really speaks to the human behavior of sometimes just not being able to take a pill every day, right? Life is crazy. I know mine is. I don't know about yours. And sometimes I might forget to take my vitamin, or I might forget to take my probiotic, or all of the things that I try and take to maintain my health. And so we have injectable medications now that people can receive every 2 months and can prevent HIV acquisition. We have injectable treatments that people can take people living with HIV can take every 2 months to suppress the amount of virus in their bodies and remain what we call undetectable. And we are now at the nexus of what we call long-acting injectables, where we might see up to 6 months of prevention, up to 6 months of treatment for a single dose. And we're talking 2 shots a year, potentially, to either prevent HIV and or to continue to control HIV in people who are living with the disease. And so we've certainly come a long way. We have the medical advancements. But now we have an equity issue. We have a justice issue. As Dr. Pernessa Seal mentioned, the rates are still too high, particularly in Black people, particularly in Black people in the South. And so I am so glad to be in conversation with two Black women who are doing work in academia and community in the southern region of the United States. And their work is not just in science and medicine, but it's also in community and in health equity, because they understand that regardless of how much science and research that we have, it's only as useful as the people who are able to access it. And we have access issues that have been created for a number of different reasons. And so I want to invite Dr. Foster and Dr. Mirage Bass into the conversation. Dr. Foster, I know that you have done this work over many decades, that you are a community and a population health expert. Tell us a little bit about what that means and how it applies to this conversation around HIV and AIDS.
Well, it's so interesting. And I thank you again for having me on this panel. And Pernessa Seal is definitely a hero of mine. It's interesting when she was talking about New York City. I moved from the New York City area to Alabama about 20 years ago. And I could see that the epidemic was so different. New York City, and I was in Tuskegee at the time, rural Alabama. Advocacy, very loud in New York City, totally silent in rural Alabama. So for me, just sort of understanding why that was so. And of course, the rates were going up and they still are high. I mean, Alabama, you talk about cities having high rates. The whole state is really a high jurisdiction area, particularly because it's predominantly rural. You know, out of the 67 counties, 56 are rural. So when we asked HIV, people living with HIV, where they felt most stigmatized, they said the church. And for me, a little light bulb went off that, wow, that's sad. And maybe this is an opportunity to help bridge that gap between church and people living with HIV, because they also said that although they were being stigmatized, they felt that the church was essential for them living. So their spirituality was very important to them. So we said, how can we maybe develop an intervention that will decrease that stigma? You know, when I reviewed the literature, there was very little here. We actually went to sub-Saharan Africa, where a faith group had developed an intervention around modules and educational curriculum to decrease the stigma in Ghana. It was a group in Ghana. So we borrowed that, we sort of revised it, and then we tested it. We rigorously tested it and found it worked. We tested it 3 different groups, one who had that faith-based messages and stigma messages compared to the regular AIDS 101 and then a true control, and found that it did decrease, significantly decrease their individual and community stigma, because a lot of research had not been done at that time on community stigma, much more of the internalized stigma. So we have developed Project Faith, and really lots of groups have used it, but we really have made it available online for organizations and faith-based leaders and pastors to avail themselves of it. And then one other thing, and I'll go to the other doctor. I think the access is true, decreased in the Deep South. Of course, lots of poverty and other issues around access, but the knowledge around what's available. I did a study actually with CFAR and Dr. Amy Nunn. We looked at pastors in 3 southern states, Alabama, Mississippi, and Arkansas. And we had around 60 to 70 pastors, Black pastors, and we asked all of them about PrEP. Nobody knew what PrEP, none of them knew what PrEP was. And I think that's an opportunity for pastors to really be at the leading edge of prevention, to really help communities with prevention. You know, PrEP is our only prevention tool, primary prevention tool, to really have access to it if they know about it. And same thing for some of the newer treatments. So I think the whole idea of access and knowledge we have to address. And I think the faith community is the primary group to help us do that.
Absolutely. Thank you for that, Dr. Foster. I'm glad that you brought up the Center for AIDS Research. I too worked with Dr. Amy Nunn.
Yes.
And a part of that work that you all did around learning about people's experience with faith communities birth the inner CFAR, Faith and Spirituality.
Yes, that's correct.
Collaborative of which I am a member.
Right.
Dr. Mirage Baz is the Assistant Director of the Center for AIDS Research at
great.
UNC. And I know that CFAR has been a national leader in what we call implementation science, which is really one of the newest scientific areas of study. And it's really designed to help us take evidence-based research and apply it to real world situations in both clinical and community settings. Dr. Mirage Bass, tell us a bit about your work in implementation science and at CFAR and how you've been able to translate it into that knowledge and that awareness that Dr. Foster talked about us so desperately needing, particularly in the South.
Thank you for that. So, Dr. Foster, you have set me up beautifully to talk about implementation science. And I thank you for that, because when you describe the issues of knowledge that go along with access, and then you also describe that we've got these community assets on which we can draw, like the faith community. Mm-hmm. Those are the exact type of determinants that we are thinking about when we are designing our implementation science research and our models. Right? So you'll see there's many different ways to use models in implementation science, but you're always going to see this consideration of what is the inner kind of context like in the healthcare environment? What does that interaction with the clinician look like, or the providers? But then in the real world, how does that connect to community, to access? How does that translate to outcomes? And then how do we keep replicating that in a way that addresses these challenges that we're talking about? That is the science of implementation. How do you take these evidence things that look great and packaged in these ways and really bring them into the real world? So I think if we're going to do that thoughtfully, we are looking at multiple levels at the same time. We are looking at, and this is absolutely my bias as a health coach, we are looking at the assets that were already existing in these communities. And I can tell you all that my role at CFAR has really been a wonderful opportunity to bring folks along from that perspective, because we talk a lot about deficits. Yes, there are some deficits when it comes to things like knowledge or access, but there are absolutely many more assets we should be drawing upon, like the cohesiveness of the faith community, like the fact that we have advocates like Dr. Seal, like many others who have been pioneers in destigmatizing HIV within faith communities. And for myself, when I think about an assets-based approach in my own work, it's with young people. We are so quick to write young people off that they are apathetic, that they don't care, that they don't want to be involved in this work. And I have just absolutely not found that to be the case. So I will just speak briefly about a youth-led, and I do mean youth-led, project that just wrapped up a few months back. So I'll speak to it because, unfortunately, I don't know that all the information on the CDC website exists anymore, y'all. Mm-hmm. So if I don't speak about it, y'all may not ever hear about it. Mm-hmm. It was a CDC-funded project all throughout COVID from 2020 through 2024. And it was explicitly designed with the intention that we would form a community council that literally determined everything that we did, from the name of the work to the definition of it to the scope, how we designed the needs assessment, what interventions we put in the community after that, how it was evaluated, the website that details that work, the places we presented about it, the partners that we worked with. When I tell you young people literally determined every one of those things, that's how community-led that we are talking about. This was not the way that we traditionally think about it, where it's really a researcher and then there's a board, but the researcher designed everything and the board said absolutely not.
Yeah, external board.
Yeah,
board. External
it wasn't that,
board.
Dr. Foster. I couldn't have told you what we were doing in real time because the young people were designing it. Like literally,
true community-based participatory research.
It's that. So it was like, well, I'll get back to you when the youth decide that you're allowed to know. It was literally, we're just there for the ride. We're just supporting them with resources. So I call that out because there's a lot of implementation science that went into that. There's a lot of evidence-based interventions for HIV testing and counseling prevention that we did. There were mental health resource guides because we have shown and seen that mental health care provision has everything to do with engagement and care when it comes to HIV prevention, especially for young Black folks, right? So there was plenty of evidence behind what we did, but it could not have been more real world in context. And I say it and I pull that out as a real testament to the types of assets that we have when we are working in Black communities and when we are uplifting community in our work. Because I think for me, where we need to be pushing forward is in assets-based approaches. And I think that that means in our implementation science, I think that means in our care provision, and I think that means in the way in which we are promoting collaboration between communities. And this is my last soapbox. I will turn it back to you, Ulysses. But I think for me, some of the challenges we're facing right now with the new administration and new constraints, it really calls out some of the weaknesses in our system, right? Because all of us here, whether we are clinicians, we are scientists, we are both, we know we have these siloed ways that funding is allocated, right? It can only be an HIV grant and it has to have this specific population and it has to have these exact outcomes. Every time we do that and we silo communities from the rest of their community, we are really missing opportunities to pull together assets and resources and to really have more collective impact. And I think now is an ideal time for us to be thinking about how to do that creatively together because there are less resources to go around. So I'll stop there. And I really appreciate your question, Ulysses.
Well, let's keep going. So you introduced the idea of the political circumstances that we find ourselves in. You know, we talk a lot about the social determinants of health or the determinants of HIV, but I don't think we talk enough about the political determinants of health and how what happens in the context of policy and government truly dictate the health and wellness of our population. You also talked a bit about COVID-19, and I currently serve as a principal investigator at the HIV Vaccine Trials Network, where I lead the HVTN Faith Initiative. And the HVTN and its partners came together during COVID to form the COVID-19 Prevention Network, and were responsible for evaluating and monitoring the government-sponsored COVID-19 vaccines. And we all remember during that time the public health campaigns around flattening the curve and talking about how this was going to be a group project that we were all going to have to succeed in. And we had poor messaging from our federal government agencies. And this is me speaking as Ulysses Burley, You Be the Cure, and not on behalf of any other organization. But I can say that if we had had maybe different leadership, that maybe as many people would not have died. And I look now to our current reality, and we're seeing measles outbreaks in, like we've never seen before, at a time when people can't even get epidemiological information. You talked about what may or may not be on the CDC's website. And so, Dr. Foster, I know that you specialize in community immunity, if you will, in population health. And I believe one of the core tenets of both good public health and good faith is this idea of community, this idea of loving neighbor as self. And I wonder if you can talk a bit about the current political reality that we are in, how it's impacting our sense of community, and how that does or does not translate to our potential response to HIV as we move forward.
So the political environment is dire. I heard Dr. P talk about federal funding maybe shrinking, and that made me think maybe we should be thinking of alternate funding, particularly around maybe private foundations and others, maybe building that up and thinking about that. I love what Dr. Bass said about thinking broader and more comprehensively. because we don't live in silos. The mental health goes along with the physical health, all those things. And I think about COVID-19 as an example. I got a call from the health department asking me for my contacts because they wanted to roll out the vaccine and do vaccine distribution. And I said, well, I can give you the contacts, but are you going to meet with them and establish a relationship with them and build trust with them? No, they just wanted to check the box. So that's an opportunity for us to think differently in the future with our because our public health system is broken because there's no connection and trust with the communities that need it most. So we've got to rethink that and rebuild that. The other thing that I saw was in the rural communities, the churches stepped up big time. They had educational sessions. They did the distribution of vaccines. They did the education around vaccines, really trying to educate. So I saw them at the forefront of the meeting neighbors' needs. And so I think rebuilding on those connections and politically, we have to be much more strategic politically because other people are holding the money strings and the decision strings, and we've got to. Some of us need to be controlling and holding those strings. That means some of us have to run for office. We've got to really be strategic in how we. For example, I'm here in Tuscaloosa. It is now majority minority city. 51% non-white. But the old guard doesn't want to change because they're used to being in charge. And so when we talked about trying to, change the lines and get more representation, they don't want to hear that. So we've got to fight. And this was before our current president got in. But even with the election today, the Black community has to be really united and strategic about how we maneuver this political environment and how we maneuver politically, because we have to do it. And a lot of the challenge, of course, is that the demographics are changing and the status quo just doesn't want to deal with that. So we, in addition to HIV education, we've got to do some political education. I think grassroots political education, particularly for those communities who are vulnerable and really need it. They're the ones that don't vote. Well, I went to the polls today, older people, where are the young people? So we've got to get our young people much more engaged. I loved what Dr. Bass said about assets with the youth, because one of the things that the pastors talked about, they always talked about the younger generation and being concerned about the younger generation. And that is the younger generation is the future. We've got to kind of stay focused on that as well.
Yeah, I really appreciate you mentioning how present and effective faith communities were in the deployment of public health during COVID-19.
Mm-hmm.
One of the reasons why the HIV Vaccine Trials Network Faith Initiative exists is because we understood during COVID that we weren't going to get buy-in for a COVID-19 vaccine without communities of faith. Mm-hmm. And our awareness campaign with the CoVPN Faith Initiative was so successful, we thought, what would it look like if we applied this same model to HIV? And a part of that model has been to prepare faith communities for an eventual HIV vaccine. And so we talked a bit about the medical advancements that have been made that are extending life, that are making HIV a chronic disease, if you will. Mm-hmm. But there are still other scientific modalities that are in the forefront that we need to effectively end the HIV and AIDS epidemic. And the only way that we continue to discover safe and effective, innovative treatment and prevention mechanisms is through community participation in science by way of clinical trials.
Yes.
The COVID-19 vaccine trials were the most diverse clinical trials to date. And a part of the reason was because the federal government required that in order for you to use this money, you've got to meet a certain threshold demographically in your trials. And so the days of, well, we just couldn't get those people, they just didn't want to participate. We know that that's not true, because people stepped up and they participated, and it's the only reason why we got the vaccine when we did. But we're going to need that same level of participation for an eventual HIV vaccine. Dr. Mirage Bass, I know that you do work around clinical trials and clinical research on a community level. What's been the reception for you in the South with Black and brown people around the community, around clinical trials and the participation in research? And what is it that we need to be doing in faith communities to continue to allay some of the skepticism and fears that rightfully exist in our communities around scientific research?
Thank you for this question, Ulysses. So I think you said a lot with a little, right? Because you said it's absolutely right. That righteous skepticism, that very valid, what are you coming in here to do? And what do you plan on leaving behind when you leave? That is the absolute question that I think all of us who do clinical trials facing work need to be prepared to answer, period. But if you are coming into Black and brown communities, if you don't have thoughtful answers for that, if you have not been spending the time on how you're going to leave resources behind and engage with the assets that are in that community, you might as well just not even go through the door, right? And so I think that is ground level, that's ground floor. If you're not prepared to have those conversations, you really don't have any business calling yourself doing clinical trials research in communities in the South with folks of color. I think that's part one. I think that part two is taking it a step further, because it's not just the lip service. I don't want to just have these conversations and say, well, there may not be direct benefit for you, but in the future, I'm going to stop you right here. You know what I mean? Because I think that a lot of times, even the way we write our consent forms, it has language like that in there, right? Enough. Where's the actual direct benefit for these folks? Where is the allocation of the resources in the grant to match the level of work that you are often calling on community experts and leaders to do, many of whom are in faith-based communities and can get into spaces you will never be welcome?
That's right.
So I feel like if we just started with those two fundamental things right now, you are fully prepared to have all the conversations about what accountability is going to look like to these communities that are blessing you with their participation. That's part one. And then number two, you actually had resources to match the level of investment and support you are asking of them. I think we would have a very different playing field and a very different level of progress in clinical trials research that is purported to benefit Black and brown communities in the South or wherever else. So I think it's like the fundamentals, y'all. We are not talking about inventing the wheel. We're talking about systematic things that have not been done in an equitable, transparent, accountable fashion. And we just don't have the luxury of tolerating that anymore. We don't have the resources anymore to do that. We don't have the agency and the political will at this particular moment to tolerate that. And that, again, goes back to why we have to have much more collaborative conversations across the board, because there need to be minimum standards that all clinical trials research is meeting. And I think those are just two examples of places to start that are actionable. They are not creative. They are pretty fundamental. And I think we could start there.
I think also because the relationships take time, and this is really about relationships. I remember one pastor told me, now I want to see you. I don't want to see your graduate student, because sometimes the model is when you're doing research that the graduate student is out in the community and doing the work, and you're back wherever. They said to me, we want to see you, even if that's a 2-3 hour drive. to have a conversation. I have a meeting with a group of pastors. The challenge also for me was my institution valuing the time that I was spending in the community as part of my work. And so that is another challenge for tenure and promotion, and the value of the institution looking at what I'm doing as valuable work. Because it's a little different than what others do, because I was traveling in rural areas and taking long periods of time and taking, maybe a few years establishing relationships when, the clock is ticking for the tenure and promotion. So all those things need to sort of value the values on of course, the accountability of us as researchers individually, but us as part of an institution, and how we sort of interact with the community. I love what you said about no lip service, because that's out. These communities are tired of being used and abused.
Mhm.
It's time for real, authentic, partnership relationships that benefit both sides.
Mhm.
Interestingly, your frameworks for partnership and for relationship and meeting people where they are, but also communicating well how they can benefit from these things right now, I believe can be copy and pasted to political engagement, right? And so we talk about, maybe younger generations not being as engaged politically. And I believe it's because they have been missing messaging that is not talking with them, but at them, or talking to them, that it lacks relationships, it lacks trust, and it lacks a clear, defined message as to how does this benefit me right now if I participate in this process. Similarly, I also believe that we can copy and paste this framework for aging faith communities. And so our faith communities look a lot like our political landscape. They are overwhelmingly over the age of 50, and that's me being modest. They are not engaging our youth and our young people, apart from maybe the gifts that they might offer in a worship experience. And younger generations have questions of, how is this going to benefit me right now? And we are still talking about the youth as being the future and not the right now. And so I think to use language from Dr. Mirage Bass, we don't need to recreate the wheel on this. We just really need to fully live into this idea of intergenerational relationship building. And I think we'll see that it's going to translate across our political landscape. It's going to translate across our research and medical landscape, and it's going to translate across our faith landscape to hopefully move us into a generation of people who are aware, people who are engaged. And so we've talked about the social determinants of health. We've talked about the political determinants of health. We've been talking about what I frame as faith as a social determinant of health, whether we've named it or not. And so I want to invite in our resident pastor. I told you we had people who were both trained in healing and in acts of the Spirit, Reverend Dr. J.C. Howard, who is the senior pastor of the House of Hope in Macon, Georgia, to talk to us a bit about how faith is indeed a social determinant of health, and how we can continue to bridge those gaps, if you will, around HIV and AIDS, and the role of the faith community in that response.
Good evening, everyone.
Good
What
evening.
a great joy it is to be online with you on tonight. I'm just getting out of a worship service And we had Ash Day Wednesday on Tuesday tonight, as Tuesday is our normal midweek meeting. But I just want to say, first of all, that I'm grateful to be in attendance. I want to thank each and every one of you for your wonderful invitation to share, and also to just be a part of such a phenomenal panel, and to share in that. I do apologize. I do apologize for my tardiness. I apologize for my tardiness.
Oh, you're
Nevertheless,
right on time, Doc.
Nevertheless,
I am grateful. Nevertheless, I am grateful to be here. I want to share something, particularly as it pertains to the health, not just HIV and AIDS and STIs and the like, but just the health disparity, and what you might call an epidemic, particularly in our community, amongst Black and Brown people. And I am specifically in the South, and in the South, we know how to get down in the South. We know how to fry up everything in the South. I don't think that there's anything off limits in the South that we haven't tried to fry. And so, just so the health disparity and the epidemic as it pertains to just health and Black folk, Black and Brown folk, and the ways in which I'm really grateful, because it's not at the very least, it's not a taboo topic anymore. There are various churches and faith organizations that are bringing light to health, being health conscious, going to the doctor regularly, getting your annual checkup and then some, not just getting your checkup, because in a very real sense, as many of you already know, there are many individuals who will go and get an annual physical, and they check your tonsils and your ears and your eyes and some glands and all of that good stuff. They ask you how you feel. However, it's interesting that we have to tell the doctor how we feel, but I think it's upon the health professionals to be able to identify things within us. And an annual physical won't do that. You have to get some blood work done. And I have been very adamant with my congregation and with various congregations that I am afforded to go and to speak at, pastors that I'm in connection with, to tell not just their congregations, but to tell the pastor, you need to go and get some blood work done, man, and make sure, and sister, and make sure you get a thorough blood work up, and check everything. Get a blood work as it pertains to your kidneys and your liver, and y'all know preachers. We like to have communion outside of First Sundays. It helps to keep us a little bit sane, and so you need to get your liver checked, your kidneys checked. You need to make sure that you get a great blood workup. See where your testosterone is and your estrogen. Make sure that you're doing all of these things, because you need a workup, because it's the numbers that can identify the plague or the problem. A doctor checking your glands or checking, how many times have we heard about various brothers and sisters who don't find out they have pancreatic cancer until stage 4? Well, if you get a full blood workup, that's the kind of thing that can be caught early. And so as a consequence, and particularly streamlining that to HIV and AIDS, I am very adamant, not just amongst our young adults, but I'm adamant amongst even our seasoned saints, which we know that sexual activity, particularly rooted in starting from probably before the pandemic hit, even up until now, sexual activity has spiked significantly amongst our seasoned saints, those in the nursing homes and areas like that. And so it's imperative that we continue to exacerbate, continue to enlarge the importance of health workups, continued annual, biannual, quarterly checks. And a lot of that, and I think a lot of the health disparity that we see, particularly in our community, is connected to fear of billing and to a lack of insurance and healthcare. It's a direct correlation. And I know that's another conversation for another day. However, it's very much woven and entrenched into that conversation. Many of our brothers and sisters fail to go to the doctor to get a workup because they don't have the kind of coverage that is necessary. To get a full blood workup will cost them in the hundreds of dollars. And so my prayer is to continue to work with nonprofits, charities, philanthropic organizations that will continue to sow into the work of helping our brothers and sisters with health care and with health coverage, particularly in those gaps where their insurance or their Medicare or Medicaid won't cover some of the bigger procedures or the bigger testing, the larger testing that is necessary to get a full work through of that which they need. And so the faith community is absolutely vital because Black folk, even though we've seen with the millennial and the Gen Z generation, not as much in-person attendance. However, from my studies, I actually did my doctoral work at Emory on millennial retention. And it's not that millennials and Gen Zers are walking away from the church or walking away from God. They're just doing church differently. They're doing church in a different kind of way. I have a young adult who's 2 and 2. She says, Pastor, I'll see you first and third, second and fourth. I'm in the stream. I got your back. But that's my schedule. I set up my work schedule around that. They're doing ministry and they're doing church differently. So it's not that they're not coming to church or walking away from the church. However, they're doing church differently. And it is our responsibility as the church to create those nuances so that they can do church differently and to affirm them in that. To not make them feel guilty for not coming to church every week, but to let them know, I'll be looking for you in the stream. I'll be looking for your comments in the YouTube stream. I look for you in the stream. I know if you were in church, if I didn't see you say, hey, pastor, or hey, church family in the stream, and meet them there and to affirm that. And so that they might stay committed and to stay rooted in the faith community so that you can then proclaim or advise, go to the doctor, get a checkup, find a doctor you can trust. Go see the OBGYN, my sister. Go and see a doctor and look at your to get a colonoscopy or to get your prostate check, my beloved brother. It is absolutely necessary. And when we create that bridge of trust, which the church has represented an institution of trust amongst Black and brown people historically, when we have that trust factor, we're able to better those of us who are brave enough to do such, to admonish our congregation to do these things, and then not just do that once a year or doing National Health Month or doing during Earth Day or whatever have you, but to do it on a regular basis, once a month, a few times a quarter, to hold town halls and to even have specific events centered around health consciousness. During the pandemic, we started something called Hope Fitness, and people couldn't go to the gym. And so what we did was I got a trainer who's in my congregation, and I said, let's do some old school Tybo, Billy Blanks type fitness things. And we recorded it and we streamed it on our platforms. And it was a major hit during the pandemic. People were at home doing our Hope Fitness sessions. I was in the sanctuary worn out because I hadn't worked out in a while, but it kept me working out and I got back into the gym. And we continue to do that once a month. We have a Hope Fitness session. We have a lot of seasoned saints that come out, and having those kind of initiatives and those kind of events and those kind of ministries help to foster the ability to have an easier conversation with your congregation, to ask, have you been to the doctor? What's going on? How's your blood work? Did you get it done? And they're not offended and they're not put off by it because it's a part of the culture of the church. I think that once you make something a part of the culture, it's easy to have conversations about it. And so that is my spiel as it pertains to the relationship between faith-based institutions like the church, nonprofits, and organizations, and this conversation around health. And my prayer is that we will continue to push the envelope forward and that we will continue to do the work that is necessary to keep our congregants and our brothers and sisters in those doctors' offices regularly so that they might be able to receive the care, the kind of care that they deserve, that they rightfully deserve as citizens of the United States of America.
Reverend Dr. J.C. Howard, I want to thank you for your timeliness. You gave us a benediction, if you will.
Amen.
Our time
All I can say is amen.
Amen. Our time for this
Amen.
session is up. I know that your role is just beginning in this town hall. And so I want to take the time to then thank my colleagues who engaged in a really fruitful conversation around medical advancements and health equity as it relates to HIV and AIDS. Thank you to Dr. Pamela Payne Foster. Thank you to Dr. Alicia Mirage Bass, and just really the things that I want to leave us with. Be involved in the political process, be involved in civic engagement. If you are a researcher, you need to be adherent to good participatory practice as it relates to engaging communities. If you are communities, be open to engaging researchers and clinical trials, because we can't do this without you. And for our faith leaders, just because everybody doesn't necessarily worship in a traditional sense, it doesn't mean that they don't have faith. And that means that we have to learn how to meet people where they are so that we can get to where we need to be, healing together, embracing life and love. I thank each and every one of you for your time. And I invite Elder Carrie Goodman back into the conversation to transition us into reflections by Pastor Howard.
Thank you so much, my good brother, the good doctor, the good Reverend Dr. Ulysses Burley. Thank you so much for your moderation. I appreciate you and your thoroughness in this time. So as we move forward in this virtual town hall, again, we want to thank each and every person that is joining us at this time. And we're in the final stretch of our virtual town hall. We just want to give you a few announcements as we move forward. Take a moment and join our mailing list, the Balm In Gilead's mailing list. Go to balmingilead.org /join our email list so that you can get the latest news and programming updates for our work at the Balm In Gilead. And then we have coming up the 12th annual Healthy Churches virtual conference will be, save the date, November the 17th through the 19th. It will be virtual. You can get more information at balmingilead.org. And then next up coming is the Healthy Churches 2030 Roadmap Tour, Forwarding the Black Health Agenda. We'll be starting our tour in Raleigh, North Carolina on March the 29th. And our spokesperson and our host this year for our roadmap tour will be the Reverend Dr. Jamal Bryant, and our own Dr. Pernessa Seal will be our host. So you don't want to miss out on this free one-day in-person event that is designed to transform your health and your well-being. So go to our website, balmingilead.org, to get more information on our Roadmap Tour 2025. So at this time, without any further ado, we want to turn it back over to our good friend and brother, the Reverend Dr. J.C. Howard, who is the pastor of the House of Hope in Macon, Georgia.
I just want to share in closing, and I appreciate the opportunity to do such. The Bible in the book of Matthew speaks extensively. Jesus is obviously talking about the kingdom of God, which includes us all. And in Matthew, particularly 9, he says that the harvest is plentiful, but the laborers are few. I suppose the reason why the Lord took me in that direction is simply because Jesus was act. The harvest is plentiful. We will never run out of people to help, to motivate, to encourage, to lead, not just in the ways of righteousness, but in the ways of good health, because to be healthy is to be righteous. Our bodies are a temple, and it's a sacrifice that we ought to make unto God. And so taking care of our bodies is absolutely essential in faith. And so as a consequence, it is Jesus who says the harvest is plentiful, but the laborers are few, meaning that we're never going to run out of work to do. However, we've discovered that there's a shortage of workers, individuals who will toil the land, individuals who will offer their time and their talent and even their treasure and their service for the benefit of another, without recompense, without a pat on the back, without your name in a magazine, without being recognized on social media, but for the sake of the kingdom, for the sake of the love in which we're supposed to share and to spread that love which is of God. This work is a thankless work oftentimes. It's an arduous work, the work of serving, the work of encouraging our brothers and sisters to do everything in their power to lead healthy lifestyles, confronting and having uncomfortable conversations, asking people about their health, their blood work, what's going on with them. Do they know what's going on with their bodies? That's an uncomfortable conversation for some, maybe for the one asking, and even maybe for the one receiving the question. However, it's necessary. It is the labor, it's the work, if we're going to keep one another around for the days, the weeks, the months, and even the years to come. The uncomfortable work of sitting down with a brother or a sister who may be sexually active and just discovered that they have contracted HIV, and to let them know this is by no means a death sentence. In fact, it can be a new beginning for you. To encourage them in that way, to encourage our brothers and sisters to go to church and go to therapy. Holla at your pastor and holla at your psychologist or psychiatrist. That can be uncomfortable. That's the work. And the harvest is plentiful. There's so many individuals that we can help, that we should help, that if you're called to this work of ministry, whether it's in the medical field, whether it's in the therapist's office, whether it's in the realm of psychology or psychiatry, whether it's in church or ministry, whether it's in political spaces, it's still ministry. And we have so many to help. There are so many that need our assistance. There's somebody that needs your voice. There's somebody who needs your voice. There's somebody who needs a word from you. There's somebody who needs that conversation. And so my final words is to encourage you to continue to labor, continue to sow, continue to work. Your labor is not in vain. The Bible says that elevation doesn't come from the east nor the west, but the elevation comes from the Lord our God above. And so, child of God, I want to encourage you to continue to serve God, continue to serve your community, continue to lobby, continue to protest, continue to call town halls like this, continue to rally, continue to cry loud and to spare not, because your words, your effort will fall upon someone's ears who needs to hear it. And it will lead them to go and make that doctor's appointment. It'll lead them to go and to get that blood work done. It'll lead them to go and to see that therapist that you recommended. It will lead them to do something in the ways of righteousness. Righteousness is not just the ways in which we have defined holy living according to the Bible and according to church polity and structure. Holy living is taking care of ourselves. Holy living is waking up another day to love our children. Holy living is to kiss our spouses and our partners before we go to sleep at night, to wake up to their warmth in the morning. Holy living is encouraging even the manager that we don't like so much. Holy living is all encompassing, and it also certainly includes our health and our wellness. The harvest is plentiful. We'll never run out of people to help, which means we have to continue to run on, as the old church would say. We have to continue to run on to see what the end is going to be. I thank you for allowing me to share. Thank you, Reverend Goodman. Thank you to the entire panel, and thank you to those of you who are listening for this time of reflection. God bless you and God keep you is my prayer.
Hey, well, thank you. Thank you so much, Reverend, and thank you so much for those closing words and to the wonderful, phenomenal panel. As I was sitting here listening this evening, my memory just went all over the place, and I thought about many, many, many years of the Black Church HIV/AIDS Institute that we used to hold in Tuskegee at Tuskegee University. Those were the days, and to have our sister with us talking about the memories of Tuskegee. But more importantly, the Balm in Gilead, we've always been in the forefront of being able to have real conversation. That's our thing, to make it real and keep it real. And I thank the phenomenal panel this evening who kept it real. As we are in these trying times, we need soldiers who stand on the shoulders of soldiers to keep it real. And just thank you so very, very much. As we come to the close of this phenomenal moment in time this evening, I just want to take a moment to just thank everyone who has been a part of the National Week of Prayer for the Healing of AIDS, but a part of the entire HIV/AIDS movement. Those who are now in the ancestral realm, I can feel their presence, and those who are still on the wall fighting the fight. Thank you, thank you, thank you so much. We can take a minute and get some rest, but the fight continues. Again, thank you so very, 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 I can never say thank you enough. And no matter what we're going through, we've been through we've been through some troubled times. We, the Black folks, we know about troubling times. My grandmama would say, Nessa, these are some troubling times. But you know what? We are people who not only know about troubling times, we know how to get through troubling times. And the one thing is our faith. And I leave you with this: no matter what we're going through, the good, the bad, and the ugly, there will always be, forever, for always, and forever, there will always be a balm in Gilead. Hold on to your faith, and work without faith, without work is what? Dead. So as we hold on to our faith, we must go to sleep tonight, get up in the morning, rise and shine, and get to work. God bless you, everyone. Again, thank you. And for real, there will always be a balm in Gilead.